Okay, any questions before we start? All right. From last time, we had gone through and talked about the difference between a psychosocial and a biomedical view of health. I thought I would just give you a little bit more of an example of what it means. Okay, so let's talk about interventions now. So typically, the difference between if you take a biomedical versus psychosocial approach, we'll call it a public health approach or psychosocial approach, but it's the approach that public health takes. Biomedical approaches, what they tend to do is they tend to focus on treatments or on things that the healthcare system could do, and public health approaches or psychosocial approaches, they tend to focus more upon underlying determinants. And this comes out. So if you go through and you look at what public health kind of talks about what they should do, public health usually says that they deal with the ambulance, the gate at the top of the cliff rather than the ambulance at the bottom of the cliff. I mean, is that public health is all about preventing things from happening as opposed to just picking up the pieces after people already get sick. In the biomedical community, health system, basically healthcare, is sort of seen as, well, they're the ones who pick up things when they go wrong. It's a little bit, kind of a false or too simplistic of a way of putting it, because biomedical stuff can do prevention as well. But the main thing is that one is dealing more with upstream social determinants, and the other one is dealing more with downstream, one downstream or more immediate type of biological effects. Psychosocial also, that in public health, they tend to talk about 3 different levels of public health interventions. So primary means eliminating risk factors, so better housing, things like that. Secondary means early detection, so like screening programs typically go under secondary. And then tertiary typically means kind of better care and better advanced type of care is usually sort of tertiary type of public health interventions. Oh, the other difference is that public health often says that they focus on communities, not on individuals. I always thought that was a bit of a false choice, because like if you look at a vaccine program, which is sort of seen as a public health intervention, I mean, that's clearly focused on individuals. I mean, you can say that there's a community aspect to it, and that you have to have a certain level of herd immunity. But for the most part, it's not that different than a psychosocial type of intervention. I mean, a biomedical type of intervention, where it's usually seen as like when public health does, mass information campaigns, where they say, oh, we're doing social marketing, or we're doing, different types of health promotion. That's a public health intervention, as opposed to like a clinician giving information. But oftentimes that's just because, you don't know who to target or know how to target, so therefore you do it for the population. So even though I know that, especially epidemiologists like to say that, that public health is a population-based rather than an individual-based, it kind of gets a little fuzzy. Okay, so why is it important to make this distinction? Well, for 2 reasons. One is that it tells you where to intervene, and the second one is it helps define your level of responsibility. To give an example, like if you were to think about you're a medical doctor, and that you're trying to figure out what you're going to do, to help these patients, and that you take a psychosocial type of view of health. You say that, oh, we know health is caused by lots of different factors like housing and income and things like that. So as a doctor, then, as a medical doctor, what is your responsibility? So for example, suppose the person comes in and says, that you say, okay, take this prescription, and the person says, well, don't have any income. Is it a doctor's responsibility to get the medication for the person anyways, even though they don't have income? How many say yes, doctors are responsible for that, versus that, so the doctor can't just say, well, okay, I guess you won't take the medication. How many, does the doctor have responsibility to try and get the patient the medication, even if they can't afford it? How many say yes, maybe, don't know, or no? Yes, maybe, no. Show me with your thumbs. Maybe, yes, yes, maybe, maybe. Okay. How about if the person says, comes in with asthma, and the doctor asks, what's your living conditions like? And they say, well, I've got pets, and I've got, I live next door to a factory, and there's a field next door that just has goldenrod all the time and things. And so, the environmental stressors that cause asthma outbreaks. Does the doctor have responsibility to deal with housing? Say yes, maybe no. So you can see the problem is like, where do you draw the line, right? Where, if you're a healthcare professional, where do you draw the line between what you as someone might do versus what someone else should do? So, they would all agree that this is all important, that you do these things, but is it their responsibility to do it? Okay, so let's consider this. People in a nursing home are at risk of getting stroke. Warfarin is a drug that you can give them to reduce the chance of having stroke. Problem with drugs like warfarin is that it's often hard to tell who actually is going to benefit from it. That is that, like if you look at people and they have high blood pressure and they have, sort of at risk of stroke, and that you do it for the population, is that you kind of know that if you were just to give a whole bunch of people warfarin, is that then it's going to reduce the incidence of stroke. The problem is your models are not very good at predicting who it is that's actually going to benefit from it. That's that, two people with high blood pressure, one may get stroke, one may not. So one may benefit from warfarin, but the other one wouldn't benefit from warfarin. But if you give it to a lot of people, is that then you're going to see a population impact. Following that? Okay. So the question is, do you intervene at the population level and do it for the same thing for everyone? Or do you do it at an individual level? And do you intervene with a biomedical type of approach, or do you intervene with a psychosocial type of approach? So consider these 4 different options. So option 1, you identify everyone in the nursing home who's at risk, and you give the blood thinner just to those people who are at risk. Option 2, put it in the drinking water, so everyone gets it. Option 3, identify people who are at risk and give them an educational program that promotes exercise and healthy eating. Option 4, do it for everyone. Give everyone in the nursing home the exercise program and healthy eating programs. Okay, so you have 4 options. 1, target people, give them warfarin. 2, give everyone warfarin. 3, target people and give them exercise. Or 4, change it and make, change basically the diet of everyone in there. And so that everyone has to exercise and everyone eats healthy. All right, so show me with your fingers, how many would like, you have to show up, 1, 2, 3, or 4 in terms of which option that you would prefer. So ready? So 1, 2, 3, go. So we have a 3, a 1, a 3, a 3, a 4, 4, a 3. Anyone do 2? Okay, so let's take 1. Identify people at risk. What's the advantages of that? What's the disadvantage of this approach? Advantage, you can target people. You don't have to worry about getting them to exercise and eat healthier. And the disadvantage, it's hard to, your ability to target people is not very good. So, maybe is that because you just don't know who's really going to get a stroke. 2, advantage, Don't have to worry about compliance, right? Everyone gets it. Don't have to worry about, that you've got the population impact. So you know that everyone's going to go ahead and get the, medication. So even though you can't predict who's going to get it, you know that overall there'll be some positive impacts. 3 advantages. What's the advantage of 3 over 1? For you 3 people, why did you choose 3 over 1? Who chose 3? Come on. Who chose 3? Why did you choose 3 over 1? Uh-huh. And it's good for them, right? It's good for people to exercise and eat healthy, right? What's the disadvantage of 3? Yeah. Huh? Yeah, I want you to go. If you have an elderly grandmother or grandfather, I want you to go home at Thanksgiving this year and say to them, no, 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 don't eat the pie. Instead of sitting there and eating the pie, I want you to go out and exercise instead. Okay. Elderly people tend to not really want to be told that they have to exercise and that to change their diet and things like that, right? So hard to do. So, and also it takes a long time. It's not going to be immediate. So you've got to, is it beneficial to do it? Yes. How long will it take? Probably a while. How about, and plus you also have the problem is that you don't know if you really target the right people. So how about 4? 4 beneficial, and that everyone's, you're targeting the right people because you're targeting everyone. So you have to worry about it. You've changed the menu. So now it's kale on the menu and salads with no dressing and things like that. Disadvantages? And you're forcing them to exercise. Like, you make them, everyone has to get up and go outside and walk around for an hour. So you're going to make them exercise. Well, strongly encourage them to exercise and change, and you're going to change their diet. What's the downside of that? Yeah. So, okay, maybe we'll give them a pass then. So if you're at high risk and you can't do it, then we'll give you a pass. Everyone else, though, get your butts out there and start walking around. So what's the problem with it? Any problem with it? From an ethical standpoint, how about number 2? Is there a ethical problem with 2? No? How many say yes, there's an ethical problem with 2 versus no, there's no ethical problem with 2, or maybe? So show me yes, maybe, no. Okay, all you yeses. Why is there an ethical problem with 2? Yeah. So I'm sorry, say it louder. Okay, and you'll identify like who it may not be good for what people who. Okay, well, we'll excuse them. Everyone else, though, have your warfarin. Yeah. Wait, say it louder. Yeah. So that. They don't know. They don't know it. Well, it's good news. It's not working now. Awesome. Yeah, I think there's another problem. Why? Because some people do not eat it, and it would be eligible to just give it to them, and oh my God, who actually needs it if you go to the house. Do we do this for everyone? If people take this out, you know, they can find it. Let's see. Did anyone ask you, do you want your water fluoridated? Did someone come up to you and say, oh, good news, you know, you can opt out of the fluoridation process if you want. No, no. And is too much fluoridation bad? Yeah, too much fluoridation is bad. Do they fluoridate in every country? No. Like in Mexico, I'm told that what they do is they, you know, they come by in schools when kids are young and they give them a fluoridation pill. And so they don't go through and fluoridate all the water. So why is it okay to fluoridate, but it's not okay to put warfarin? Which is more effective? Well, warfarin would be more effective. Warfarin in the water would be more effective than an exercise program in which you force people to eat kale and march around, even though they'd be healthier, like overall from it. If your goal is to reduce stroke, then, but it sounds wrong, right? It sounds wrong to sit there and say, well, you know, we're going to put, because warfarin is essentially rat poison. We're going to put rat poison in the water. That sounds bad. People don't like that when you say things like that. And so, you know, fluoridation is something for which we've kind of gotten used to. And a couple of years ago, I had a student who he was asked by by California Department of Public Health to essentially update the literature on the benefits of fluoridation. And so, you know, I thought, oh, that's a nice project. It's a cost effectiveness literature. That's what he's supposed to do. Update the you know, in terms of the cost effectiveness literature on fluoridation. And so I thought, oh, that's nice. And so, you know, I have him start going through it. And then, you know, we started to talk to Ricardo Cisneros, who's, you know, professor up here of environmental scientists. And Ricardo is not very positive about fluoridation. And, you know, because he points out that there's lots of problems with it if you over fluoridate, that there's a lot of variation in water systems in terms of how much fluoridation is in there. And so if you get it wrong, you know, it can be bad. So, you know, and then he also points to the other ways to do it if you really want to do it, et cetera. So, you know, so we were going through and having a spirited intellectual discussion about this. And so when it came time to write up the results, I asked the people from CDPH, I said, well, you know, do you want me to, you know, how much do you want me to say about some of the literature that talks about the downsides of fluoridation? And within a day, I suddenly was on a call with like someone from Michigan and someone from Washington and all these different places who are like these, you know, national experts in fluoridation who are there to you know, convince me that no, this is fluoridation is a universally good thing. And so they didn't want a report coming out from CDPH that said that there might be problems with fluoridation. So, and then they strangely just never asked for the report. So they just dropped it. So, you know, clearly the public health community has drank in the Kool-Aid on fluoridation, you might say, in terms of, you know, it's universally a good thing because they don't really want to get into a debate about, you know, to open up the door to a debate about, you know, do we really have to have fluoridation everywhere and things like that. So the point is that, you know, that's a biomedical intervention. The fluoridation thing is a biomedical intervention. Right? You could do other types of public health interventions that would, you know, protect teeth, but the fluoridation is just a lot more effective. So there are times when biomedical interventions have kind of the advantage over public health interventions. The problem is that biomedical interventions like that, you know, kind of require that you start to, you know, give people treatments that they may not necessarily, you know, have agreed to do. And so that's why 2 sort of seems like it's unethical. 1 is okay, but 3 and 4, I think from our public health standpoints, we think those are the preferred ones to do. Okay. But, and so this is the challenge when you start taking up the public health type of you know, psychosocial intervention approach, is that, you know, the advantage of a biomedical approach is that if you could find the silver bullet, so to speak, to kind of cure something or prevent something, it can be a lot easier to do. You know, like a vaccination is a, you know, perfect example of something where, if you can get a vaccine for something, it's a lot easier to do that than it is to try to go through and to convince people to distance and things like this. So, the downstream biomedical, the biomedical approaches, have their advantages in a lot of cases. The problem with upstream ones is that they can be more difficult to do, and that, you may not be able to change it. So, if you look at like what a lot of public health interventions that talk about what public health departments do, when they go through and that they look at their, they look at their needs, do their needs assessments, and they identify these needs in the population. Oftentimes there's things like, better employment, more employment, better housing, better, all these things that are upstream type of things that are truly, impactful to people's health. But the problem is that public health really can't do much about it. I mean, they can try and do some things, but they're not really in control of the employment situation. So when it comes to interventions, oftentimes the public health ones start to get a bit fuzzy. So take the COVID vaccine, right? When the vaccine came out, it was clear as that it was going to reduce death rates and reduce the spread. Not eliminate death rates, not eliminate spread, but it would reduce it. And if you could reach herd immunity, that then it would kind of be you'd have even more benefits, right? So public health was faced with this question about what should they do? Should they go ahead and just sort of say, well, if you want to get vaccinated, you can get vaccinated. But if you don't want to, then you don't have to. Should they do, number two, which is that say that, well, we're going to encourage everyone to get vaccinated. And if you don't get vaccinated, there's going to be some type of, special kind of things that are going to happen to you if you don't get vaccinated. Or number three, just require everyone to get vaccinated, which is, they technically could try and do that. So which one did public health do? 1, 2, or 3? Let me say 1, 2, or 3. What did public health do? They did 2 pretty much, right? Because they didn't require people to get vaccinated. They sort of said, places said initially, well, if you don't get vaccinated, you can't come back into work or you can't do whatever. But they never really went that far as to actually, go through and try to require that people get vaccinated. And then after time, they just kind of let that go. So they didn't try to do it because there was so much pushback on it. They also tried to, some public health departments tried to do, pay people to get vaccinated. Did that happen here in Merced? They do a campaign where they'd offer you $50 to get vaccinated. And that turned out, from what I understand, to be a colossal failure. Because what happens is that people who had already vaccinated said, where's my $50? And people who weren't vaccinated said, this is the government trying to control you by making it so that, that they're, this vaccine is causing all these horrible things. And now they're trying to pay you to take it. Okay. Point being, that's what, when we talk about the biomedical versus public health, that's where it comes out. It comes out when you start to do interventions. Well, it comes out in 2 ways. One is what's your responsibility? That's that, do you think you have responsibility for upstream things? Or can you just sort of deal with, can the healthcare system just focus on what the healthcare system does? And the second thing is that if you do a more expansive public health intervention that's, that deals with the underlying fundamentals and the, of health, the social determinants, is that it suddenly becomes a lot harder to do. And it also becomes you're dealing with things that maybe you don't have the power to control. Okay, so last time we started talking about wants versus needs. We're going through this list. Let's see. And then I said we were going to go through this one. So the question is, will you pay for my facelift? Will, as part of the healthcare plan that I get, should my healthcare plan pay for me to get a facelift? I may say, yes, you can get a facelift. We'll support you, our healthcare plan paying for the facelift, versus no. No, why not? But look at. I'd look great. Just like a little eyebrows up, just a little tuck. I'd look really good. Say it louder. No, why not? Why isn't it neat? Yeah, but when I think that, if I did this, I'd be much more. Because I want to be really tough. I need. So you have my second that I'm very impressed. Then we do. Yeah. Well, because you're telling me, you're telling me that I shouldn't care about what people think. And of course, being a kind of person, I care about what people think. So they want, they better be look more surprised than that's makes me doing. What I'm doing is Thomas say yes, we'll pay for your place. Versus Thomas say, no, I'd like to fill the cost. Okay, but but you're saying is that it's a want, but it's not a need, because I don't need it. And that the reason that you think that is because, you think, well, very accurately. There's a lot of things people get older, they shouldn't be focused on, their happiness should depend on you. So all very true. Right? But if that's your opinion, your what client might be different, should be really important. So why is it that you telling me that it's you're not going to be there just because you know about it, or it's not going to be. Yeah, also it's okay because I feel like that. If you feel like the need matters, then I see why that would be excellent. I guess it'd be a need, but it's still not. Well, it's a lot because you are an expert. You are projecting your values on it, and you're saying that in your experience, this is something that people don't need. This is in your experience that people want. Right? But the question is what can people be different? Can people be different enough that how in society, how do we I think if I wanted to get a facelift, my insurance company would say no. However, if I got in a car accident and was burned on part of my face, then my insurance company probably would say yes. So what's the difference? Well, but my health is the same in each case, right? So it's not like from an infection standpoint or something else. You just got very scarred on one side of the face. And so insurance company comes in and says, okay, we'll get that. How many would you do that? If I got in a car accident and was very scarred on one side of the face, and they did and plastic surgery would travel, would you agree? Okay, so what's the difference between the two cases? Yeah.
I mean, if you're sorry, you might feel different, not everyone sorry. That was gonna the problem, that was pretty way. So we were saying now, we're going that way. So we said, if you went in an accident, that's
when I was born with so you I was born.
So that's great. So that's also like is been very common.
Yeah.
So we like
but so you got some standard about someone here that there's a pattern.
Don't keep going sort of way, but then when we look back at it, it's like, hopefully they're gonna tell you, but I mean, like you can't go in an accident, what if we got you?
Well, by that definition, is the reason why. Why? I mean, that's the definition of your preference, but I have a preference that if I'm with it, I want my way to do things. So why are you saying a class of me? But people get around without, like on wheelchairs, people just say use your wheelchair. Right. So why are you looking at, fix my leg, if you're not really, why are you're going to say that that's a need, but if the other things are just costs. Yeah. So medical means like it's something the medical community can do something about. And that is, it's, when I'm trying to distinguish between caseless at this point. It's something that the medical community can do something about, and it's, normal. Is that what it is? Yeah. So the quality of life is like, big exposure because, like, there was, maybe that's the, some mobilities, yes. Or, if you needed some kind of surgery because medically you didn't get the doctor, you have all the things happen, or like a flat power, you might actually have trouble throughout your life, there's for example, or the quality of life. And that gets one of the things like, what's your level of passion? And you're coming around, you feel like you're gonna support my basic things.
So, like, for that situation would be in need or something like this, you take the action. Otherwise, it's hard.
I think the face like I could go down the bar down here. I'd be much better, much better. And I could do it, but I think that with face that I'd be much more attractive. I think that, and that's important to me. So therefore, you're still on my side. Put it face that because I'm go down to the 19th Street. Yeah. How about there was it's still done somewhat, but there was some program that was basically so they wouldn't be homosexual. Talked about in the 1990s. It's called the rising called the gay out. California's banned now, right? Was California right to ban that? I was thinking it's California. No, what do you think? Is California right to ban that? Or how about gender reassignment? It's that's something for which 10 years ago, 15 years ago, the most was that society didn't pay for that. Now, except for Florida, it's sort of seen as another need. So why is it that gender reassignment therapy has gone from being something which was, not even seen as a want, right? It was seen as something that's needed, but suddenly seen as something which is more of a recognized medical need? Well, what this all highlights is one is that you're very hard people for not agreeing to give me my facelift. But the other thing is that this idea of what's a want versus a need is not something which is set in stone, is that it depends upon what society kind of sees. I mean, and your response in terms of going through and sort of saying, no, you don't think I need it, is kind of what everyone does, right? We all sort of have to ask ourselves, does this seem like it's a reasonable thing to do? And that but this idea of wants versus needs is something for which it's not static. It changes a lot. It changes as society changes. It's called the mirage of health, in the sense that that you kind of, it's not like there's these set things. But in what the reason why it's important for what we do is because if you think about like going into a doctor, right? And the doctor, and you have some type of issue, is that the doctor is going to make a decision about whether this is a want or a need. I mean, sometimes things are covered, so it's your right whether or not the doctor thinks it. But there's a whole other class of things for which, it comes to what their view is, whether this is a want versus a need. And if it's and so that means that we're kind of in a world where there are external kind of forces that come through, and that they can decide what it is that we're going to get, even if I was truly really depressed about my face to the point of being suicidal. If I was suicidal and said, if I got a facelift, I wouldn't be suicidal anymore. Then you might sort of think, well, okay, maybe you need counseling, and maybe part of that counseling will end up being a facelift. But there's a process we go through. But it does mean that you're kind of starting to grapple with the idea that people can differ somewhat in terms of what's really, really important to them. And that, you would like your healthcare system to be flexible in that sense, to be flexible to the fact that people can have different needs. All right. So when we start talking about, and the reason why this is important is because, or for the class, is that when we start talking about what kind of healthcare, what our healthcare system does, is that by the biomedical model, what the healthcare system does is it deals with needs. And so what that has traditionally meant is that the healthcare system deals with things that, that the doctors sort of see as needs, and that things that the doctors didn't see as needs, like lots of women's problems, women's issues, were sort of seen as, well, these are just things that happen in life and not necessarily medical problems. So when we talk about need, then, there are different types of ways that we determine what needs are. So one is express need. So that's what people say. So when I say I need a facelift, that's an express need, right? But more generally, like this is, if you go out there and you do a survey and you ask people, what's your biggest problems in the community, your biggest health problems in the community? You're asking them their express need. The other one is comparative. So when you were considering my facelift after the accident, and you said, well, compared to other people, is that, you're different and we can do something about this, and you want us to do something about that. So that's a comparative need. At the population level, the way this comes out is that, if you look at what the needs are in Merced County, is that what often happens that they sort of say, well, what's the rates of cancer in Merced County versus other counties? What's the rates of asthma? What's the rates of all these different things? So they compare it to other type of places. That's comparative need. The normative need, that's where someone decides for you. Either it's an insurance company, or it's a healthcare professional, or it's someone who sits there and says, oh, well, no, you don't need this. And then sometimes that's, valid thing to do, right? Because if I come in and say, doctor, I have a need because, Martians have been invading my brain, and I really need you to take out the front part of my brain. I'm expressing a need, but I think as a medical professional, you would say, your need is probably not Martians coming down. Could be, right? You don't know. Could be, but it's probably not. It's probably something else. Okay, I'll put this online, but let me pull it up here. Where is it? It's Merced. There it is. So this is Merced County's, community needs assessment. So all public health departments at one point, and every couple of years have to do a community needs assessment. So what they do is they go through, and you will see they look at social determinants, access to care, then leading causes, then modifiable factors. So health, obesity, not a health condition, but not a disease, but it is something which is a modifiable risk factor, and pregnancy, etc. And they come down and they, kind of just go through and give the data for Merced County. So that's a typical needs assessment that you'll see. So I pulled out some. So what I want you to just tell me, is this expressed, comparative, or normative need? And this is a great test question, just to let you know, where I'll give you some type of quote and ask you which it is, expressed, comparative, or normative. So first one, however, low-income Merced residents and those without dental insurance are less likely to see a dentist than Merced County residents who are middle to higher income. Expressed, comparative, or normative? Say expressed, comparative, normative. Two, right? Two. It's comparative because they're basically comparing, without dental insurance to those who are high income. Merced County has higher rates of blindness, vision problems than California, though comparable to the US. 1, 2, or 3? 2, right? Again, Merced County mortality rate was due to heart disease higher than California, but both are above the 2020 goal of 103 point, 100,000 population. 1, 2, or 3? Well, actually, this one's both 2 and 3, right? It's 2 because they're comparing it to California, but it's 3 is that they're basically comparing it to this goal of 103.4. So, why did they get that 103.4 as the goal? Doesn't really say. So, but that's a norm. What they've done is they've set a normative standard. And so they're trying to see, is it meet a normative standard? 49% of the key informants considered heart disease and stroke a major problem. 1, 2, or 3? 1. 1. It's expressed, right? Because they're basically saying what people think. 49% of Merced County key informants could have said that Martians are the biggest problem, and that would have been an expressed need. 1 out of 4 school graders is obese. 1, 2, or 3? 3. Because they're basically just sort of saying, they're saying 1 out of 4. They're not saying whether that's good or bad, right? But the assumption is that somehow this is bad. And so that's basically, they have some normative standard that they're using. So that's a 3. Okay, questions about that? All right. Okay, the next assignment, which I'll give you on Thursday, is about health insurance. So I'm going to go ahead and spend the rest of the time talking about health insurance, and I'll probably do it continue on Thursday and probably into next Tuesday as well. All right. So first thing to realize is that all healthcare is basically health in all countries is basically health insurance. As if you think about, what insurance means is that insurance is something for which you don't know what's going to happen to you, and you don't know how much it's going to cost if it does happen to you. And so therefore you go and you buy an insurance plan that covers you in case of a loss. So the two things that you need for insurance to work is that you need to have uncertainty about whether something bad is going to happen to you, and you need to have uncertainty about what it's going to cost. That's when people buy insurance. And so what insurance contracts do is that insurance contracts specify what it is you're going to receive. And insurance premiums is what you pay. So, the way premium insurance works is that you pay a certain amount every month, regardless of whether you have a loss or not. And the idea being that if then something happens to you, then they come through and they pay you a lot more to cover your loss. So y'all have, how many people have car insurance in here? Okay. So you have car insurance. So what's your car, like, what does your car insurance cover? So what's it cover? So what's the term say? How much you pay a month or a year for your car insurance? Well, I think I pay, it just went up. I think it's like $1,100 per car for the year, something like that. It's about what I pay. And we don't have nice cars. So I think it's about $1,100 per year is what we pay for a car. So that's probably about what most people pay. If you have a really nice car, you pay more, right? What else do you pay more for? Like if you have insurance, who pays? Yeah. Yeah, so if you get a speeding ticket, they raise your rates, right? Why? Why did, yeah, so what, because it means what? It means that you are more likely to have a car accident, right? So what they're looking for is they're looking for signals for what your kind of level of risk is. So they want to split you up as much as possible into kind of how risky you are. So people who are risky are, who's risky? Young people. Young people are risky. Males are more risky. People what? People who just got the license, more risky. Old people, more risky. People who drink, more risky, right? You know, me who drink alcohol, more risky. Students, less or more risky. Well, some insurance companies offer good student discounts so that if you're in university, is that you pay less. And then if you get good grades, then you pay less. Why do they do that? Well, because, they've identified that people who get good grades in school are going to be better drivers or less likely to get an accident than people who either aren't in school or in school but don't get good grades. So that's the way car insurance works, right? So the way it works is that, you pay a little bit, right, in your premium, and that then they're taking the risk. And that what they're doing then is that they're going to, if you have an accident, they'll come through and that they'll pay for it. So you pay a little bit, but you hope, like fire insurance is the best example. We have fire insurance for the house. We pay a certain amount every year for the fire insurance. And I hope we never have to use it. In fact, because we live in Mariposa, we used to pay $1,500 a year for our fire insurance. And then last year, the insurance company came through and said, oh, we're canceling everyone. So most people in Mariposa have now lost their insurance. So the only way that we can get insurance now is we have to go through, there's a state plan called CalFare. And so our insurance premiums are now $8,000 a year. Why is our insurance premiums $8,000 a year? Why did the insurance company pull out from covering people in Mariposa? What do you think? Yeah.
Because the area is susceptible to fires.
Yeah, wildfires, right? Because there's been so many wildfires, and what the insurance companies are doing is they're looking and they're saying, well, with climate change, all these areas are going to burn, or at least are susceptible to burning. And so what they don't want is what the insurance companies don't want is they don't want to insure a whole bunch of people in the same place that have the same thing happen to them, right? So what they want is they want to insure things for which there's a random event. A random event's like a house fire, a random event Doesn't happen to everyone. Problem with forest, wildfires is that they sweep through and they take out everyone in an area. So if you're insured, all these people in this area, everything gets covered. You have to pay for everything. So that's why insurance companies, like take hurricanes. Why do insurance companies not cover hurricanes or earthquakes? Because most insurance companies won't cover acts of God, right? Like hurricanes or earthquakes. Why not? Because they wipe out, they go through Florida and they wipe out entire communities of Florida. And so insurance companies want things that are random, not things that wipe out whole lots of swaths of things. So what insurance companies do is that they basically base their premiums. They look at how much, let's say if this many people here, and they go through and they figure out how much losses this group of people is going to have. And then they charge you all same amount to cover their losses. And so that's your premium. And then what they're thinking is that, well, they can estimate kind of how many people will have certain type of, bad events happening. And so therefore they know kind of what their expected losses are. But if the bad event happened to everyone, then they'd go broke. So they can't, and they wouldn't be able to cover things. All right. So key concept that we're going to talk about a lot is what's called a fair premium. And so a fair premium is basically the amount per person that's charged that covers the losses for the insurance company. So if you think about like this 10 people, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And they look at these 10 people and they say, who's going to have a loss? So maybe they say, 2 people is going to have a loss. And they say, how much will the losses be? And the losses will be $5,000 per person, like that. So that they have $10,000 total in losses for this group of 10 people. Then they're going to go through and they're going to charge everyone, basically, 1/10 of 10,000. So they charge everyone $1,000. All the way down. So they charge everyone $1,000. So that's how they figure out. That's how they're basically charging premiums to cover their losses. That's called a fair premium. So a fair premium is when the expected loss, the sum of the expected loss equals the sum of the premiums. Now, what about profits? Well, the insurance companies actually make profits. Yeah, but insurance companies, and this won't be on the test, but insurance companies actually make profits in 2 ways. So one is that they'll really what they do is that they have the premiums expected losses, some plus some type of profits that go into it. But the way that most insurance companies make money is that they, you think about what an insurance company does is in January, they take all your premiums. So they have $10,000 in premiums. And then let's say there's one loss in March of $5,000, and there's one in December of $5,000. Right, so let's say it looks like that. So what they're doing is they're taking $10,000 here, and and 3 months later they pay out $5,000, and 11 months later they pay out the other $5,000. Well, what do they do with this $10,000 that they brought in? Well, they invest it, right? They take it, they put it in stocks or put it in whatever, so they get a certain amount of return from this. So like right now, interest rates are about 5%, something like that. So that means that if they were to invest this for a year, they would have, $10,500 by the end of the year. So that means that, they, even though they're paying out $10,000, they potentially can have $500 profit. It's also why, once your loss comes in, Does the insurance company have any incentive to pay you off right away? No. They have every incentive to drag it out as long as possible. Because the more time they drag it out, the more time that they can basically get interest off this money that they brought in. So it's why, insurance companies, and we'll talk about this when we start talking about how insurance companies operate in health. But essentially, the longer that you can delay something, the more money you. So it means that if a healthcare provider calls up and says, hey, I just did this operation on this person for 5,000, please repay me. The insurance company, the longer they can delay that, the more money that they make. So that's how insurance companies can make their money. They make their money either by having some excess amount here, like that they charge for premiums, or they make the money down here with interest rates. And so, this one is a little bit tougher to do because, everyone looks at just what it costs you. So they want to keep the premiums as low as possible. So they tend to keep premiums really low, but then what they do is that they try to increase the amount of time it takes to pay off losses. Like my brother lives in Lahaina. His family lives in Lahaina, and they, when the fire came through a couple weeks ago, they, lost. Well, they didn't lose the condo they were living in, but they were building some houses, and that they lost those. So most people, that they know lost all their houses. And so, the question is, well, what's going to happen now that? And so what's happened is that when FEMA gets involved, right, when the Federal Emergency Management Agency gets involved, is that they basically tell the insurance companies, we're going to cover everything. We'll make sure that everything's covered. So therefore, the insurance companies then have an incentive then to just pay it off right away because they know they're going to get reimbursed for it. Why does FEMA do that? Why does FEMA come in and sort of say, we'll pay off, most of the insurance claims? Well, because, it's something where they know that people need their money right away, right? They can't wait around. And again, my brother was trying to get the insurance company to come out and to look at the place. And the insurance company says, well, we have to send people out there to look at it first. And of course, since after a fire, one of the things that happens is that everything's toxic. Like we had a fire up in America, it was a couple of years ago, and that burned a bunch of houses. And what they told people is that, if you touch anything that's there, is that then the state won't come in and help clean it up because everything's toxic. And so they don't want you to go, they don't want you to go through and try and clean up your stuff yourself. And when they came in, they came in hazmat suits, and they came in with big, trailers, and they just dumped all the dirt in, sealed it up, and took it to, so probably the Merced. But they took it someplace else, all this toxic material. So that's probably, that's what happens after you have a fire, is that you end up with all this toxic stuff. And so as a result, insurance companies, if they may have the requirement that they need to go there and inspect it, they may not be able to inspect it for 6 months. And so to get around that, what FEMA says is that, well, look at, insurance company, we'll guarantee that everything gets paid. So therefore you have no incentive now to delay. And the whole reason they're doing it is just to get people the money quickly. So the insurance company doesn't do this type of thing. Okay. So let's see. 10 people buying car insurance. They knew it was going to cost $2,000 each, right? In losses. So what would be the fair premium for this? Well, first off, let's talk about how do they know, how do they know that it's going to be $5,000 in losses? So how does the insurance company figure this out? Like, how do they know about what it's gonna, how many, for this group of people, how do they know how many losses you're gonna have? Well, they have all your driving records, right? And they know what your characteristics are. And they know kind of what your age and everything else. And they look past records and they see, well, over time, how many people like this, how many accidents did people have? And what they're doing, these are all actuaries. So if you ever want a job in that where you get paid a bunch of money to become an actuary, in an insurance company. But what's based upon is this. So let's say that you have people can go from 0 up to 100,000, let's say, in losses. So these are your losses here, and this is your probability here. Well, for car insurance then, how many people have 0 losses? Like in the past year, how many people did not have an accident? How many people did have an accident? Okay, so no one had an accident. So most people had no accidents. So that's what's going to happen. Most people have accidents like this. And then if you, so this is probability. So let's say that this is 80% of people have no accidents. Oh, we'll change it to 90%. 90% of people have no accidents. How many people will have like one accident that, you know, for like $1,000? Well, probably like this, right? And then what happens is that the distribution gets lower and lower and lower like that. So that there'll be like 1 or 2 people who had a really, really big accident. You know, they crashed into a Mercedes-Benz. But for the most part, you know, it kind of looks like that. So you have most people have nothing, and then in fact it goes like this, right? It goes like that. That's what the distribution looks like. So then if you take the average amount, well, the average amount is going to be someplace like here. So the average amount is like $3,000 for this group, let's say. Because there's some people that have really big ones, most people have nothing. So you can figure out the average. The average is about $3,000. Follow me so far? Okay. So then, if you take that $3,000 and say, okay, here's the median, and then you look over time, and you do this for a bunch of different groups over time. Then what happens is that, well, you get a distribution. That sometimes the average is a little bit higher than 3,000. Sometimes it's lower than 3,000, but it starts to look like this distribution. This type of distribution is called a normal distribution or a bell curve. It's called a normal distribution. But it looks like this. It's centered around the mean, and then it gets, you know, you get kind of means that most things are going to be in this area. It's very unlikely, but possible that some year, you know, the average would only be 1,000, and it's possible that some year the average may be 5,000. Unlikely, but possible. But it looks like that. Right? Following so far? So now, what happens if you, rather than using this as the group, you use 1,000 people as the group? What happens to this distribution? It gets narrower. If you have 1,000 people, then you can still be centered on 3,000, but it starts to look like that, right? Because what happens is that as your sample size increases, it's like you're much less likely to have a number of like 1,000 or 5,000. And if you use not 1,000 people, but you use 1,000,000 people, then what does this distribution look like? Then it's just basically this distribution just looks like this. Like that. But this is n is equal to 1,000,000. This is n is equal to 1,000. And this n is equal to 50. So essentially, as you get higher, your distribution becomes more pointed, right? More. What that means is that you're more certain that you're going to be in this type of area here. So when you think about, so insurance companies, what they want is they want lots and lots of people who look exactly the same. Because if they can get lots and lots of people who look exactly the same, then you can pretty accurately determine what their losses is going to be. On the other hand, if a natural event comes through, like a hurricane, then what happens? Well, then suddenly everyone has a $10,000 loss. And so if the insurance company was thinking, oh, it's $3,000, but then it happens to everyone, so that it's actually $10,000, then the insurance company goes out of business because they've lost, you know, they undercharged. On the other hand, it also means that the insurance company is not very likely to be down here and make a whole bunch of money. Because at 1,000, because the chance that you're gonna get only a 1,000 is almost nothing. So that's why when the insurance companies, what they want is they want a whole bunch of people who are exactly alike. And so what that means is that then they're gonna categorize you to different type of risk categories. So those risk categories could be young versus old, it could be, male versus female, it could be drive flash car versus drive a bad car, it could be anything. The insurance companies really, they're not gonna care about what kind of information they use as long as it predicts, because that's what they wanna do. They wanna be able to predict your risk as much as possible based upon your characteristics. And once they do that, then they know how much to charge you. It's also why if you suddenly get a ticket, you go from this, up to this, because you're in a new group now, right? You're now in a group that has a speeding ticket. And so now, you're at $5,000 instead of $3,000. It's because you've now, signaled to them is that, oh, you're not a low risk person, you're a high risk person. And so it moves you up. And that's the way insurance works. What about things that are really rare? Like, what about things where, because this assumes that you can get a whole bunch of different things are exactly like people and, and categorize them by their risk. But how about something like container ships, right? Something for which there's a lot less container ships. Can they still go through and do this? Not as easily. You may have heard of Lloyd's of London. Lloyd's of London they're famous for insuring things like Taylor Swift's legs. Something like that. You can get insurance policies for everything. There's no 1,000 Taylor Swifts out there that they can figure out what the probability of Taylor Swift going to break her leg. But you can still go, they can do it because what they do is they get a whole bunch of odd things and then they kind of lump them together. So there are ways that they can insure very, very odd things, but you can see it's very risky. At some point, it leaves insurance where the idea is to get rid of risk, and it moves into basically just gambling, where they're hoping that something doesn't happen. Okay. We'll tell you what, why don't we stop there, because on Thursday I'll show you some more examples about how this works. Is there any questions? Okay, see you on Thursday.